Thank you so much for sitting down with me today to discuss considerations for managing patients with hematologic malignancies during the COVID-19 pandemic. What would you say the situation with COVID-19 looks like in Seattle right now?
Um, Thankfully, the situation is stable to improving by almost all of the measures that are being used. So we get frequent updates from the inpatient side, which for us is the University of Washington Medical Center at our institution, and then also from the outpatient side at the Seattle Cancer Care Alliance. With updated case counts and number of people being discharged from the hospital and that kind of thing, as well as the statewide information that gets published frequently and updated by the Department of Health. So it looks like the overall number of cases has decreased, but there are still hundreds of cases that are being diagnosed every day, and on the order of 1 to 2 dozen deaths that are being reported every day. So I think while everybody is breathing a sigh of relief that things didn't reach the absolute worst that they could have in terms of what was predicted for the potential surge and in terms of what was seen in other parts of the country, we in Seattle escaped some of that, but at the same time, it doesn't feel like we are out of the woods.
It's a very good point. Um, Maybe you could walk me through some of the precautionary measures that have been put into place at your institution to ensure the prevention of the virus within the community.
Yeah, we've done a lot of things, and it has been a little bit of an evolving response. So I will say that what I tell you should be up to date right now, but that's not to say that it won't shortly become less up to date. So one of the big changes that has happened has been universal masking. So everybody, healthcare providers, patients, visitors, anybody who comes through the Seattle Cancer Care Alliance doors is expected to wear a mask, and they're provided with one if they don't have one. Another thing that goes along with that entry into the cancer center has been that there is one site where everybody enters the cancer center and everybody is screened with a questionnaire, and then able to get their mask. And if necessary, if any symptoms are reported by a patient or a family member who's accompanying the patient, or from a staff member, they can be appropriately triaged to get tested for the COVID virus. We also have a COVID nurse hotline, so patients who have symptoms are encouraged to call the hotline before they come to clinic to avoid potentially exposing people in the clinic, and that there are drive-through testing sites where patients can undergo testing if necessary, again, to reduce the exposure and risk to people around the patient. So that's some of what's been done to decrease the exposure for symptomatic patients. There's also a body of evidence that's growing suggesting that there's asymptomatic transmission, and that anybody who has the virus is not always aware that they have it and may be shedding the virus in that kind of circumstance. And so going along with that, there's been a lot of encouragement of working from home for people who can do that. For a large clinical trial center like ours is, we have a rotating system for the clinical trial coordinators so that they now only come in if necessary. Sometimes there's now a thought that maybe they will Zoom in to some of the telemedicine visits. So we're working on trying to figure out what that's going to look like, again, with this idea that we're not completely out of the woods yet, even though things weren't as bad as they absolutely could have been. I think one other thing that I alluded to was this move towards telemedicine. So while many of my patients with hematologic malignancies still need to get their labs drawn, they maybe don't always need to have a physical exam. And so whenever possible, we've been moving a lot of those visits to telemedicine. So the patients will come in at a quiet time, for example, on the weekends when it's usually very quiet in the lab and there is minimal exposure to other patients in the waiting room, or staff or family members of patients or that kind of thing. We'll get their blood drawn, and then maybe a day or two later, we'll be able to have a telemedicine visit. So that decreases the exposure and the person-to-person transmission risk significantly.
That's great. Thank you so much for sharing. And then obviously, you covered this a little bit, but testing is obviously a critical component right now of everything that's going on. How are you, maybe you can expand a little bit on how you're approaching testing in practice, and are you experiencing any challenges or shortages there?
So we've been very lucky that the University of Washington Virology Lab really was able to develop an in-house test that was able to reach the clinical certification levels and be able to be ramped up pretty quickly with the capacity to do thousands of tests a day. So thankfully, we haven't had a lot of shortages in terms of testing, and we've been able to test everyone that it seems appropriate to test. And that's a little bit of a moving target in terms of who is appropriate to test. So for example, right now I'm the inpatient leukemia attending at the University of Washington Medical Center. And now when patients come in, if they're admitted with a complication like neutropenic fever, even if they don't have any chest x-ray findings, they undergo at least 2 different tests for COVID-19. One, because every patient who gets admitted to the hospital gets swabbed for COVID-19. They're not necessarily put into respiratory isolation and precautions, just unless the test were to come back positive, which would be unusual but possible. But then the fact that patients have a fever when they have neutropenic fever is sufficient to get a second swab, so 12 to 24 hours later, to make sure that that's negative and that we weren't sort of catching the virus right at the beginning of its replication. So maybe the sensitivity of the first test wouldn't be sufficient to detect the virus. So I think we are lucky to be able to have enough testing at our center, and I think that that is true at a number of the hospitals in our region. It's more of an issue to be able to get adequate testing at other facilities like long-term care facilities, where sometimes our patients may need to go for rehab after hospital stay. So I know that there's been a push in the state of Washington, at least, to devote separate spaces to patients who have COVID infections, maybe are recovering from COVID infections, maybe are being discharged from the hospital after having had an infection. So to have a separate wing of a nursing facility, but really still be able to care for those patients and treat them appropriately if they are found to have any symptoms.
Great, thank you. And kind of leading up to the paper that we're going to be talking about, what are some of the unique challenges that the pandemic presents with regard to providing optimal management of patients specifically with hematologic malignancies?
So patients with hematologic malignancies are kind of a unique subset within cancer more broadly, because a lot of the times, even for patients with relapsed or refractory disease, but certainly for patients who are newly diagnosed, we're treating them with curative intent chemotherapy. And additionally, the chemotherapy can be very toxic to the normal immune system. And that's a given even in non-pandemic times. So when patients are being treated with these really toxic therapies during a pandemic, it really brings up a lot of questions about the best ways to manage patients and to try to decrease their risk of exposure to the virus, but also other complications that may land them in the hospital through no fault of their own. So for example, one issue that we deal with a lot is neutropenia, having a low white blood cell count and an inability to fight off typically bacterial and fungal infections with the same capability as somebody who is non-neutropenic. So for neutropenic patients, we are more liberally using growth factors to try to decrease that duration of neutropenia and decrease the amount of time that patients need to spend in the hospital and hospital-like settings because of the potential of spread of the virus in that sort of setting. And then also for hospital capacity constraint issues, that hasn't been as much of an issue. But again, if there is a surge or something like that, where there are questions about adequacy of the number of ventilators or other supportive care measures that are available for patients, we're trying to decrease the burden that our patients would need to put on the system if it were stressed.
Great, thank you. So you authored a paper on considerations for managing patients with these malignancies during the pandemic. What were the steps that led up to that paper, and what was your kind of inspiration for putting that together?
So it came out of hallway conversations. So Dr. Ajay Gopal and Dr. Andrew Cowan and I realized as we were taking care of our various types of patients who more broadly all have hematologic malignancies, but who have a lot of differences in their care, we realized that there were different considerations that maybe other people would benefit from thinking about and learning about. And we were trying to think about what would we do differently in the time of the pandemic. So Dr. Gopal primarily cares for patients with lymphoma. Dr. Cowan, primarily patients with myeloma. I primarily take care of patients with acute myeloid leukemia and myelodysplastic syndrome. And so we decided to approach a group of people that we work with who treat different subsets of hematologic malignancies and think about what particular considerations they were coming up with. So one example that Dr. Cowan came up with that we put in the paper that you referred to is part of the treatment for patients with relapsed or refractory multiple myeloma often includes an anti-CD38 antibody known as daratumumab. And daratumumab can be a really effective treatment for patients with relapsed or refractory multiple myeloma, but something that I was unaware of because that's not the primary patient population that I care for, but that he made note of is that the rate of upper respiratory tract infections is consistently higher in patients who get daratumumab, and that's been published previously. So given that, if he has a patient who has stable disease or a low burden of disease, he and some of his other myeloma colleagues are considering holding a dose or, maybe keeping the patient off for a longer period of time, maybe a period of weeks or months while the pandemic is ongoing to really make sure that he is not predisposing patients to adverse risk outcomes with the COVID-19 virus.
Thank you. And I'm wondering if maybe you could discuss some of the other malignancies and give me a little taste of some of the recommendations that you put out for those as well. I know your specialty is AML, you said, so maybe you can discuss that a little bit further.
Yeah, so for patients with acute myeloid leukemia, it's often considered an emergency when the diagnosis is made and treatment is initiated very quickly. But if you look back, there are actually a couple of retrospective analyses that have been published that suggest that it's okay to wait a period of time, more like on the order of days to weeks, not months in most cases. So it is still something that needs to be treated urgently, but that suggests that there would be time to test a patient for COVID-19 and wait for those results, and possibly to be able to support a patient through a diagnosis of COVID-19 without feeling that immediate pressure to initiate treatment that often happens when we see a patient with a new diagnosis of acute myeloid leukemia. Additionally, at our center, we have done a couple of clinical trials to examine whether it's safe to administer outpatient induction chemotherapy, again, with that goal of trying to decrease the burden of hospitalization for patients. And that is safe in a pilot study that was published in Blood Advances earlier in 2020. So that's something that we have done more of during the pandemic period of time. And then also we often, again, based on a clinical trial that was published, we often discharge patients after the completion of induction chemotherapy, whereas at other centers, they're kept inpatient for a full month while they're waiting for their blood counts to recover after chemotherapy. And so those are some interventions that would be reasonable, that other centers may not be as aware of, but may be more willing to adopt during this period of time.
That's fantastic. I'm sure everyone's going to find that very helpful. So I know one of the big questions right now for patients with cancer who are also infected with the virus is, how do you know when it's safe to restart treatment for their cancer after they've been positive? Like, so what are you doing? Are you testing and waiting for a negative result? Or are you just waiting for a certain amount of time? How are you dealing with like the false negatives?
That's a very good question. So patients who require hospitalization for their COVID-19 infection do get swabbed to see if they have cleared the virus prior to discharge. So, for example, I have a patient with a history of acute myeloid leukemia who has some residual low blood counts but doesn't have active disease right now, who was admitted about a week and a half ago with a COVID-19 infection. And she was very ill. She required ICU stay and pressor medications to keep her blood pressure up, though she did not require intubation or really much in the way of respiratory support. And so when she was ready to leave the hospital earlier this week, she was swabbed to try to determine whether she was still shedding active virus. Because she was negative, actually the way the recommendations are written, she doesn't need to take more precautions than the average person. When she is kind of out and about in her life, she doesn't need to quarantine at home away from her husband or anything like that. She's still doing a lot of self-isolating at home. But then when she comes to clinic, one of the screening questions that is asked of everybody is whether they have had a positive COVID-19 test in the past 30 days. Since her answer to that is obviously yes, because she was just hospitalized for it, and because my team already knows about her, we're prepared for this. But patients with a positive test are kind of escorted so that they don't go through the lab and that kind of thing, and really minimize their exposure to other people in case there are things like false negatives that we're dealing with in somebody who's had a confirmed infection.
Great. Thank you for sharing. Was there anything else that you wanted to add regarding the paper that maybe I didn't ask you about?
I think one thing is to speak a little more generally about cancer, because it's hard to know exactly what the interplay is between the virus and other comorbidities that patients may have, cancer being just one of them. There's not a whole lot of data out yet about patients with hematologic cancers in particular in terms of their response to the COVID-19 virus, but there is some data from China because they're a little farther ahead in time in terms of exposure. There's a little bit of data suggesting that outcomes are a lot worse for patients who have a history of cancer who end up getting the COVID-19 virus. And that's both in terms of requiring ICU stay and then also in terms of overall mortality being higher in patients with a history of cancer. A lot of the publications have not really drilled down on the type of cancer yet. I think there will be more information that's available, but I think that really underscores the importance of primary prevention and really just trying to reduce exposure so that patients with blood cancers or any other kind of cancer don't get the virus to start off with.
That's a very good point. And that's actually all I have for you today.
Okay.
Thank you so much for taking the time
Yeah.
to speak with me. I really appreciate it.
Happy to do so. Thank you.